I'm Sandy Mahlango from Eswatini Hospice at home. We are apologizing for the delay. We were assisting Manzini Hospital to join. They are having some technicalities, so we are hoping we will not go long. They will have joined us also. Today, we are having our session. We are looking closer to finishing the assessment of pain. Last week, we were looking at how to assess qualitatively pain assessment. We looked at different things that we have to look for. We were looking at the multifactorial model that help us to assess pain, looking at the different factors that can contribute to pain. So at this time, may I request that we introduce ourselves for the sake of those who may want to get the CPD points from us. Each session can give you up to 1.5 points. So those who will need us to assist them with that, we also request that you introduce yourself by writing your name or on chat, and then your contacts, possibly your email will help us to know who exactly you are. So your name, your profession. I'm happy to see that Zwane has already introduced his team. So I think that what is missing now is the emails of the participants is joining me. And then also we have seen Patizo also introducing himself. If also can just add your email there. So it will help us then to be able to identify in terms of when you need some assistance. It also helps us to understand who and who is with who. For this time, I would request Zinhle and your team to introduce yourself. Maybe Zinhle will introduce them so that we can see if we are all audible enough. Zinhle, do you get me? Hello, Zinhle.
Can you hear me?
Yes, we can hear you now.
Yes, my name is Zinhle Zwane from RFM, Palliative Care Department.
Yes.
I'm with Nonsigelelo Ntuli. I'm a nurse with Nonsigelelo Ntuli, who is a nurse also, and we have our 3 social worker interns, Bongiwe, Nomcebo, and Nomvuyo.
Thank you. We hope we will enjoy to have you. Maybe also if Patizo can introduce himself.
No, okay. Oh, Fabuta Nomcebo, social work intern at RFM Hospital.
Thank you.
Okay, thank you for having us. I'm Bongiwe Tembe. I'm also an intern at RFM.
Okay, thank you.
Yes.
Hello, everyone. I'm Nonsigelelo Ntuli, a nurse at RFM Palliative Care Unit.
Yeah, thank you.
Yes, that is all from us. Thank you.
Thank you. Patizo, can you introduce yourself, sir? Patizo, do you hear us? May I kindly request the parties to also join with his audio. I think if he's joining with the cell phone, it is showing him some gadget or headset. I think he will need to allow the cell phone to join also with the audio. You can just go to your settings on top and then it will allow you to then say join the voice call too. Yes, Patricia, can you introduce yourself? Do you hear us, Patricia? Maybe meantime, I will request my Gameta to introduce herself.
Thank you. Good afternoon, team. I'm Zota Gameta, working for Eswatini Hospice at home. Thank you.
Thank you. With me, I have a big team here with nurses, a social worker. So I will request them to introduce themselves to you, team. Here they are. I will start with the one at the front.
Good afternoon, colleagues. My name is Mercy Shabamo. I am a social worker.
Good afternoon, team. I'm Sponges Milane. It was a thank you.
Thank you.
Good afternoon, team. I am Nondudu Zotani, Hospice at home.
Thank you.
Good afternoon, team. I'm Charles Owen, also at Hospice at home.
Thank you.
Afternoon, team. I'm Samuel Mukele. Thank you.
Thank you. We are so happy, and others we are hoping they are joining us on the way. So I'm seeing Prudy, Sister Prudy. Hello, Sister Prudy. Okay. I hope everyone can hear us this time around. So I was saying last week we were looking at the qualitative assessment of pain. So we look at the multifactorial model. So today we also look at a case from Babani that was also affected with pain, and then we also encourage the issue of total pain assessment. So today we are looking at the other aspect on how best we can assess pain. So we will be looking at the quantitative assessment of pain, or looking at the intensity part in PQRST. So today we have Mr. Ukele to take us through the quantitative assessment. Then we will also then have a case presentation from RFM Hospital Palliative Care Unit by Nancy Zitler. So this time, may I give Mr. Ukele to give us today's didactic session.
Good afternoon, colleagues, once again. We are still on pain assessment. As Mr. Mahlangu said, last session, we talked about the qualitative of pain assessment. So today, we'll be looking at quantitative pain assessment, which is the pain intensity. It will be a very short and brief presentation for today. We'll look at few things. As the outline here shows, we'll be looking at the introduction, pain intensity, assessment scales, pain assessment tools that we normally use when assessing pain to our clients. Then we will be looking at the key points, take-home messages. So in our introduction, we can see that quantitative assessment is pain intensity assessment, which is the magnitude of experienced pain using assessment scales. So we mentioned last session that without proper pain assessment, you cannot give an effective intervention for our clients to get proper medication, pain medication. So we need to dig more in pain assessment. So although pain is subjective, self-reported experience of which is self-reported experience of the patient, the ability to quantify the intensity of pain is essential to monitor patient's responsiveness to analgesia. So every time you give out an analgesia, every time you give out pain medication, it is very essential to monitor the patient's responsiveness to it. In order for this is part of assessment whether the analgesia or whether the pain medication is worked to the particular patient that you are working on. Then the next point, although pain assessment tools have been made available, there is a concern about healthcare professionals' inconsistent use of the word purpose on pain intensity scales. So it is very important for us to familiarize ourselves with this pain assessment, with the pain tools, pain assessment tools, so that we can have a good pain assessment and give out effective pain medication to our clients. So inconsistent use of or different workers may yield different pain reports. So commonly we use these 4 assessment scales. They are not only the scales that we use in pain assessment, but these are the common one that we use and that are available in the country. The first one is the numeric rating scale. We will see it in more details when we proceed with our presentation. Then the second one is the Wong-Becker Faces Pain Scale. We also have the 5-finger pain score, and the common one, is the 5-finger pain score, which is used in most of our facilities here in the country, and it is the pain score, or it is the scale that most of our clients understand. We also have the flag scale, which is used in most cases in non-verbal situations like in pediatric, because we know that children cannot relate, cannot point, cannot show where the pain is. Yes, it is subjective, but in these cases of non-verbal situation, we use the flag scale. So as you can see, we have these pain assessment tools that we can see there. We first see the 5-finger score. The most important thing here is to ask the patient to show how bad the pain is with their hand. It is, as I've mentioned, the previous slide that this is the most common that we use as healthcare professionals, especially in the rural settings, rural communities. They understand best this kind of tools, the 5-finger score. With that one, it has got, we know that the scores are 0 to 10, and these 5-finger score represent the scores from 0 to 10. So as we can see that our first year, the first one shows that there is no pain. Then the first one, it hurts a little bit. Then the second one, which is 2 fingers, it hurts a little more. It's moderate. Then the number 3, it shows that, okay, 2 and 3, it shows the heads, it hurts a little more. Then 3, it hurts even more. Then 5, it hurts more. It hurts a whole lot more. So when we look at the numeric one, we can see that it says the same thing with the finger 5 score, which is the scale from 0 to 5, whereby from 0 it indicates that there is no pain. Then in score number 10, it shows that it is worst pain possible. So you ask the patient, you find out how the pain is, the intensity of the pain. Yes, we have found out that the quality of the pain, the type of the pain. Now you need to dig more about the intensity now, how the pain hurts. Is it mild? Is it moderate? Is it severe? Is it very severe, or is it overwhelming? So in the number, the numeric ones, as you can see that it has different colors, which shows that in green, the green one shows no pain or mild. Then the yellow one shows moderate. The orange one shows severe to very severe, then the red one shows the worst pain possible. This will help you as a healthcare worker, the type of medication you are going to use. This will help you to determine or to decide whether you are going to use an analgesic, or whether you are going to use a weak opioid or a strong opioid. This will tell you, you cannot give an analgesic to a patient who has the 10 score here, and you cannot give a weak opioid if the patient indicates, or the pain score indicates that it is 1. So these numbers or this intensity shows or will make you to decide what kind of medication or pain medication are you going to use to the client. Then the next two here is the phases. We normally use these phases on children. It is the same one as the flag scale, whereby we have got, as you can see, we've got 6 different phases here. The first one is a smile face, which indicates that there is no pain. The second one is the 1 to 3 score, which is also mild. Then the yellow moderate, 4 to 6. Then the orange one, 7 to 9. Then the 10 one, it's the red. Where is the worst pain possible? So with these different phases, it indicates how the pain is, and It will show the patient, or the patient will show his face how the pain is. Is it mild or is it overwhelming? So the next one is the next assessment tool we are going to use here is the pain, is the blood pain scale. So sometimes here it is difficult to assess pain in children, like I said before, who are non-verbal. There are other clients who may show non-verbal situation other than the children. So the blood scale here is a system that can help parents and professionals assess pain levels with children who have limited or not expressive communication. So as you can see the diagram below, it has got different kind of categories, 5 to be specific. There is a face here, there are legs, which is the F for blood scale, the F stands for face. So there are things that you are going to assess there. You assess this things like the physical examination. So you assess the face, you assess the legs, you assess the activity, you assess how the baby or how the child cries here. Is there any signs of crying? So when you console the children, is the children or is the child able to be consoled? Is it easy to be consoled, or it is difficult to console or to comfort? So as you can see, the categories here, there are categories. In the table below, there are categories. There is a score of 0, there is a score of 1, and there is a score of 2. There are only each category here is called on the 0 to 2 scale, which results in total score from 0 to 10. As I've said, that all assessments here, all the tools, all the pen score here always is from 0 to 10. Then here on the flag scale, as I have mentioned, the categories for score 0, there is no particular expression of a smile under the category of face. Then score 1 is occasional increments of frown, withdrawn, and disinterested. Some of the things that this child here is not interested in. And in score 2, which is overwhelming here, frequent to constant quivering chin and clenched jaw. So you can see, and you can see how the pain is, or how the intensity of the pain is through this scale, which is the flag scale. So you also assess the legs, how are they aligned, or how are they and you also assess, are they normal, are they in normal position or relaxed? In pain 0. In pain 1, you can see the child restless. You can see the child very tense and uneasy. In some other times, the child may kick the legs drop up. That will show you that the pain is severe, which is on score 2. Then you also look the activity, or how the child moves, what the child is doing. In score 0, lying down quietly, there is assume a normal position and moves easily. Then in score 1, you can see that the child is swimming, shifting back and forth, and there is very tense as well. Then in overwhelming stage or in overwhelming score, the child is jerking. There is a rigid position, then he act. So in score 2, you can see that this is the child's overwhelming. This is to identify the intensity of the pain. Okay, the next category, you can see that the pain is the child is crying in different score categories. In score 0, there is no crying. The child is awake or asleep, but is calm. But in score 1, in score 1, the child, you can see that the child moans. There is occasional complaints. Sometimes the child can cry steadily, screams or sobs, frequently complains. So you can see that the pain is overwhelming. So when you are trying to console this child or that person who has when you can, okay, this child, when we try to console that child, because we have learned that there is limited or no expressive communication here. The child here is content and relaxed in score 0. Then in score 1, when you are trying to reassure the child by touching, hugging, or being talked to, you can see that there is the child response, there is a responsiveness that is happening there. Then in score 2, in overwhelming pain, when the pain is overwhelming there, it is difficult to console or comfort. So every time you do that, you can see that the pain here is overwhelming. If the child here is showing these behaviors, it doesn't necessarily mean that they are in pain, as some of the other measures measured by the Clark scale can happen for other reasons. However, parents are advised to follow up high score with a professional. So every time we come across these situations, every time we come across with this these people or these individuals who have no expressive communication, you need to consider this kind of pain scale, which is the Clark pain scale. So it is very important to use each and every type of the scales that we have discussed, but you have to first identify or to assess the condition of the clients that you are with. If the client cannot communicate well, you decide which scale you are going to use, because it varies. This scale varies from different society to the other. It varies from people to people. There are other people, individuals who are learned, there are other individuals who are not learned, of which you are going to use the numeric score. There are some people that can give you a best response if you use the numeric score, but in some people, like you cannot use the numeric score because they are not learned. Some of them are very illiterate. So the best way or the best tool to use, assessment tool, is the five finger score. Some of them you can use the Baker versus pain score. So the key points here, or the messages, the take-home messages, the pain is multifactorial and affects the whole person and family caregivers. So it is very important as healthcare workers to take it seriously, so that the family, so that the person or the patient and caregivers can be happy of the services that we are providing to them. There are multiple barriers to pain assessment exist. So patients should be screened for pain on admission to the hospital, clinic, nursing home, hospice, or home care agency. So pain assessment is done everywhere. Where there is a facility, health facility there, you need to screen as a healthcare worker for pain. You need to do a thorough pain assessment. If pain or discomfort is reported, a comprehensive assessment should be performed at regular intervals. Whenever there is a change in the pain, and after any modifications and pain management. Reassessment of pain intensity should occur within 1 hour of analgesic administration or other non-pharmacological intervention. This applies more in the patients that are admitted at hospitals. Every administration of an analgesic, we have to assess the intensity of the pain for our client. So the patient's self-report of pain is the gold standard, even for those patients who are non-verbal or cognitively impaired. So here it goes back to the fact that it is very important to hear what the patient say, because the pain here is subjective. So it is something that you hear from the patient. So evaluate pain assessment instruments used in your care setting, ensure evidence-based, valid and reliable culturally sensitive tools are being used for your patient population. So the last point that I will add here is documentation. In every assessment, in every pain assessment that we be doing, it is of prominent importance that as healthcare workers should document for the better results, for continuum of care, even if the next healthcare worker attends the patient, so that the treatment plan will not be disturbed. So in every patient, we have to do a proper pain assessment, so that our patients will get best services that we improve as healthcare workers. Thank you very much, colleagues. I hope it was clear to anybody. I will end here for today. This marks the end of my presentation. Thank you very much.
Thank you, Mr. Kele, for such a wonderful presentation. There are things I've noted from the presentation. In fact, they are a build-up from our previous presentations, especially from the start to now. Most of them, they go back to the fact that communication is the backbone of palliative care. Without good communication, we are going to miss a lot of. May I request Manzi Hospital? Yes. So we are going to miss a lot of things in palliative care. From today's presentation, there are a few tools that were presented to us that also help us to assess pain. What I've noticed is that some of the tools were initially designed for children, but in palliative care, we adopt them for cognitively impaired people. So even children who cannot communicate to us, we use them. Especially the flat scale. There are patients sometimes at the advanced stage of the disease. Sometimes they will be unable to communicate to us. So then we have to objectively assess the pain using the flat scale. So then we will rely on it. But for those patients, sometimes I think next week we will be looking at closer, the non-verbal patient. One of the scales that sometimes we use is that we need to create what we call meta-communication with our patients, whereby we are able to have an established relationship with your patient such that you understand how you communicate to one another. The very important thing with this tool is that before you attempt to use them with your patient, first invest in educating your patient about the tools themselves first. Get to understand how they interpret it and what they understand about the tool, whether the patient is pain or not. You will find that during the time you are enrolling the patient into palliative care, one of the education topics you have to put is that one of the pain assessment skills. Is to teach them why it's important to report about pain, and then teach them why it's important we measure the intensity of pain every time we do assessment of pain and how we are going to measure it. So all those scales, I've learned and understood that even the learned people, they fail to interpret the numeric scale to tell us how they feel until we educate them so that they are now able to put it in the scale. Oh, this is how I can interpret what I'm feeling to be. So other issues that we discussed in the previous is the issue of social, cultural, and developmental stages. In Africa or in other parts of this country, if you are going to meet a man and then you show him a fist and you tell him if your pain is 0, or if there is no pain, show me a fist. That man will be very angry at you. And you will tell him you can't say it's a fist and there is no pain, because a fist is a killer. So I will interpret a fist as a high pain. So, and it's so important that you establish one consistent interpretation with each and every patient. If it's possible, it should be consistent with all your patients. That if I'm saying 0, it's a fist, then I mean it's a fist. Because some will show them the faces, they will fail even to tell you what that means. Establishing even non-verbal skills with your patient, it helps because we know the trajectory of the disease sometimes goes worse. So if then we know how we talk, even non-verbal with the patient, it becomes easier even when they are unable to talk. Let me say a patient has a orophageal cancer or has a certain cancer that is metastatic to block the hearing. The patient cannot hear you, or sometimes the patient cannot express verbally what he is feeling. But with the ability to use this sign, they are able to then to give you the scope of what the patient is. Mr. Mpandi emphasized the issue of documentation. We can all agree that some of us who don't have these tools in our facilities, we are unable to use them. So some of us, we have them, but we don't scale the pain there. So that we are unable to know if we are making it or we are not. We just rely on subjective information, yet even if it's subjective, if they will scale it, you are able to trace on that. That's what I can say I've learned from what he's saying. Maybe I don't know if anyone would like to ask or add. This is one of the interesting topics that is so challenging in the field of practice. Anyone with a question, we can share it on chat. You can raise your hand and then we talk. anyone who wants to ask a patient, or you want some clarity on how best you can do this in your facility, because most of them we are missing them when it comes to pain assessment intensity. I have an experience whereby a patient will say, my pain score is 10, because he thinks you are not going to give the medication. And then if you ask the patient, saying the pain score is 10, and when you ask the patient on treatment, what treatment have you been using to control such pain, then the patient will say, I've been using Panadol. And then you will find that he's saying that, or she's saying that because she doesn't understand the scaling thing you're talking about. So the data education on what does it mean and how to rate it. So you have to explain until the patient understands. Then from there, you can then allow the patient. But we are always tempted to say, oh, in a scale of 0 to 10, can you tell me what is your pain? And the patient is like, what are you talking about? And then the patient will say, I 1. Because the patient doesn't understand what we are saying. 1. It's 5. He shall say a number because he doesn't understand what the scale is all about. Even if you ask him to signal with the hands, the patient will just give you a sign. He doesn't know even what does it mean. Or sometimes he knows, or she or he knows what it means, but you don't know what the patient is meaning. I don't know if anyone experienced such, or you can share how have you gone about. It's a very challenging. Anyone to say something on the pain intensity assessment? I don't see anyone saying something. I don't know whether it means not intent to expose. We had one case from in the past from Manzini Hospital of a patient with hearing loss. I don't know if Tandazi or it was Nompumelelo who shared this case. I don't know. I don't remember. There was a case there. I don't know if how best they were assessing the pain. But I remember that one of the things they were using, they brought a caregiver who was there to help with interpretation and stuff. I don't know whether the caregiver was aware of the scale. I don't know. I don't want to expose Manzini Hospital, but I am aware they had such an experience of attending to a patient with cancer, if not mistaken, and had a hearing loss. I don't know if you can be free to share your experience with that patient. How best did you maneuver through? Or if he is still around? Okay.
Hello, Tim. This is Nana from Mazuli Government Hospital.
Yes.
Oh, I just want to make clarity that that case was presented by Nompumelelo,
Yeah.
who unfortunately she's not in country.
Okay.
Yes.
All right. Thank you. All right. So it was an interesting case that required us to build on the skills. But for now, maybe while we are still thinking, I know we may share our experiences maybe after this case presentation. So we can share. We need to assess whether how did you go about, you know? I've been assessing an 80-year-old man who don't even remember when he was born, you know. But he will tell you, I am pain, you don't know even how to get the intensity of the scale. After data education, Because most of the things that destroy us or make us fail to get the intensity scale, we fail to educate them basically. What is pain, how to express it, why is it important that you express it? If there are scales, why is it important to use the scales to understand them? And then once you've educated them on that, once they understand, unfortunately, it becomes the language for them to express themselves. If they move from hospice to Manzini Hospital, they will use the same language with you. And it's, my pain is the whole headness, and then you will be frustrated. What is the whole head? Because maybe that's what the communication was with the patient. That's why even communication and documentation is so important between us to know, oh, patient so and so was assessed and was able to express the pain intensity scale using his hand to say the fist was 0 and the thumb was the highest ever with pain. And then the other healthcare worker to take care of that patient will read the continuous care paper and will understand, oh, the initial time they were assessing this pain, they used this skin and this is how it was interpreted with the patient. Then you are going to be able to review it. Or they used the Walker face, or they used the flat scale, or they used the numeric. Then you will understand, oh, if I'm assessing pain for this one, I'm going to use the numeric scale. That's how it is when we have documented it and made it clear which tool we have used. If then you say the patient has challenges with A, B, C, D, maybe intellectual or what, it helps continuously. Even if you are a social worker, you can do that. I don't think you can provide psychosocial in a patient associating pain, but you need to understand how much the pain is the patient experiencing, so you can interact with the other professionals in the system to say, oh, I talked with the patient, he said the pain is this much. I think you need to intervene as quick as possible because it is affecting the patient. It's when you know how the patient is describing his or her pain. May I request Zinke to share your case presentation for today? If you have anything to share, may you kindly also put it in chat. If you have not introduced your team members' name, may I request that you introduce them on chat, write their name and the people you are attending with and their email IDs. It can be so helpful. Zita, are you there?
Yes, I'm here.
We have already shared the case presentation for you. You can go on.
Oh, thank you, Mr. Marshall. Hi again, everyone. My name is Eswatini. I'm a registered nurse at RFM Hospital Palliative Care Unit. Today I'll be sharing with you a case. We have a follow-up of 48 years old female with chronic venous ulcer. The main problem of the patient is that there is poor prognosis of the condition. Patient is now developing some blisters on the left foot and upper leg that progresses to sores, and the sores are septic. And the main concern is that there could be a development of squamous cell carcinoma, thus delaying the healing process. The chief complaint, holistic assessment, briefly, the chief complaint, non-healing ulcer above left angle since 2016 assessment. The client is clinically stable, fully awake and well-oriented, and where there was a wet dressing on the left angle that is having a bad odor. Can you hear me?
Yes.
No. Okay, thank you. The pain assessment The duration of the pain has been 4 months. Description. The patient said it's stabbing and sharp, and it's overwhelming. In score 5, said it's 5. The periodicity, it's mixed, constant. Sometimes it comes and goes. And the precipitating factors, she said it's worse when she's moving. The relieving factors, she said the pain, it's better when she's seated and taken some medication. And she said it affects her sleep sometimes and also affects her mobility. And with the pain medication, it's partial. The pain evaluation form, the clients came to us on 26 September when we started to evaluate her pain. Pain location was on the left ankle. The scale was 5/5. Intensity, it was overwhelming, and duration, she said it's for 4 months. And the possible cause was that the wound wasn't healing, so it was also septic. And the doctors ordered the morphine solution, 5 mils. And then the patient came on the 5th of October. And the pain then was severe. And she was given morphine, 5 mils. And he started on antibiotics, cloxacillin, 500 milligrams QID. And also the doctors ordered that we do dressing with the Inadine and Adaptic on alternative days. And the client then came again on the 7th, and the evaluation of the pain was mild to moderate. And the possible cause was that of the poor healing of the wound. But now the patient said she was now responding on Panado only, no longer taking the morphine. And she came for a change of dressing. And also the doctor suggested that they book the patient for biopsy. Progress following intervention. The client said she was in moderate pain, and the wound there was some slight change. The wound wasn't having a bad odor, reddish in color now. And some of the sores from the blisters have healed. Medical history. Patient was enrolled on palliative care on the 26th of September. She presented with an ulcer on the left ankle with severe pain. She was diagnosed with venous ulcer in 2016 after experiencing some trauma on the left leg in 2015. Patient have been dressing ever since. Was once done skin graft in Babane government, which wasn't successful. Medications, current medications, the patient is taking morphine 5 mils for hourly, bicycodil 5 milligrams nocturne, PCM 1 gram TID, and amitriptyline 25 milligrams nocturne. Social history, patient is employed, occupation is a teacher, education, tertiary level, socioeconomics class. She's in the middle class. She's married, and lifestyle habits. Patient is not smoking or taking any alcohol. Relevant health condition is close family members, none known. And we didn't do the advanced directive because patient is not qualifying for that one. Review of systems. The blood pressure was 92 over 65. Temperature is 34 degrees, 34.3 degrees Celsius. The pulse was 91, SpO2, 98%. Pain score was 3/5, which is its moderate pain. Functionality score. Patient is ambulant, but is always using a crutch. There is no dyspnea. Some slight anxiety is moderate, with some mild depression because of the condition. And the focused investigations that were done, she did a full blood count with some slightly elevated white blood cells. The HB was normal, and the patient did biopsy on the 13th of October and is currently awaiting some results. The further plan, the client has been seen by the surgical team, who's the one who did the biopsy. They ordered that the wound be cleaned with salt solution and dressed with adaptic and inadine on alternative days. Client has been also health educated on the importance of proper diet to enhance the healing process. That was the end of my case presentation. Thank you.
Thank you, RFM for the case presentation. We have a patient here who was diagnosed with a venous ulcer, with a poor prognosis of the patient condition. Was diagnosed with this problem since 2016, and is a 46-year-old, maybe I may open this floor to the colleagues to ask the questions. My question would be, when did the patient started to use the crutch? And the pain assessment tool that was done for the patient, the one that was used, and how maybe the patient responded with the pain assessment tool. Those would be mine, but let me open it for other team members to ask a question or add or for clarification in this case.
The patient started to, she came to us already using the crutch when we enrolled her for palliative care.
Okay.
And sorry, I didn't hear the other question, Mr. Masang.
That which intensity or pain assessment tool was used for the pain assessment and how the patient was able to understand. Put it now. Hello, Zinhle. Zinhle, are you there?
Sorry, Mr. Masang. We use the numerical scale.
Okay. It's an interesting case, no? Maybe you could share the experience. How did it happen? Maybe the patient understood well from the first phase, or he had some challenges, just for the benefit of others, maybe who have not tried to use the numerical scale for such clients.
Sorry.
Maybe you could share how best you help the patient to interpret her own pain. I saw that on the initial date, the patient was able to interpret the pain to 5 out of 5, and then but later the pain then went down a little bit. So maybe you could share the experience, how you helped the patient, because on the 26th, on the 5th, on the 7th, you were getting different variables from the patient. Maybe you could share with the team, this is what we're doing, and this is the experience we've got from this patient.
Okay. Can I ask my colleague Nelson to elaborate on that one?
Okay, we know it's a team. Was it easier for you to help the patient grade in her own pain?
Oh, hello, everyone.
Yes.
Usually, I assess the knowledge of scaling his or her pain that for that particular client. If she or he is well oriented about the pain scaling, she or he will tell us the exact scale of his or her pain. But if he is not well oriented on pain scaling, I use the fingers and then explain that first finger, maybe I will say it's smaller, it's first finger is a bit, second is smaller, it's painful, it's severe on the fourth one, then the last one, it's unbearable.
Thank you. Thank you for sharing that. I don't know.
And it also depends on and it also depends that it's a child or an adult.
Okay.
Yes, if it's a child, you also use the face, you look at the patient. How is the pain when you look at the child? And then you do your scaling. Yes.
Oh, okay. I mean, the worker faces, it's you who interpret it based on your observation of the patient, facial expressions.
Yes. And then yes, it's a difficult.
Okay. Okay, thank you. Thank you, other friends, for sharing your experiences. I think from today, there's something you have got on the tools. They are not easier to work or to use with our patient. But what we can emphasize is that on the worker phase, you allow the patient to show you which face depicts his or her feelings. Most of the time, it works well with the children, especially the school-going ones. They can show you the face that exactly expresses how she or he feels. But then, if it's gonna be objectively assessed for the young ones who cannot express themselves, then we advise or recommend the use of the flag scale, because that's when you will observe and then pick those things or the behaviors of the child. So then you can use that one. Or else the patient is a non-verbal patient or who's on bed who cannot communicate, then you can use the flag scale on them. Then if it's the adult one, you will maneuver as you are saying with the scale. I'm not sure if you are consistent with your patients in terms of which thing that you say what. It's one of the gray areas that needs some study that we need to explore through and see. I don't know if anyone wants to add on and ask RFM Hospital. I know that one of the challenges that comes with the venous ulcers is the issue of obesity. I don't know, is the patient not overweight or obese? How is the BMI of the patient? Any other underlying conditions that she has?
Sorry, Mr. Matlang, we're having network difficult. So what is your question again?
I was saying that one of the patients who are at risk of developing the venous ulcers can be patients with obesity or overweight. So I wanted to know how is the BMI of our patient or any other underlying conditions except that now she has this problem.
Oh, the client is having varicose veins. So it's like the venous ulcer developed from that because of the trauma she had. There is no obesity. Her weight looks good.
Yes, okay. Maybe you can help the team on the trauma. Are you there?
Yes, we are here.
Yes, maybe you can help the team. You were mentioning that the patient had trauma.
Oh, okay. She said that she went to a funeral. While they were cooking there, she entered the hall and she was hurt on the ankle, around the ankle, the left ankle. And then that's where the ulcer started. 2015.
Oh, okay.
Yes.
So she has not narrated that when she has started to use the open stick.
Oh, sorry, Mr. Matang, we didn't ask her that, but we enrolled the patient 26 September. She was already using the crutch.
I don't know if other colleagues have questions or suggestions or anything to get to understand the client that is on the table today. Any question you may ask Nazarene, or we can comment with them on what they've done so far.
Colleague, maybe I can ask if during the course of treatment for the client, unfortunately, I'm not sure when the blisters developed, but my question is, was compression stockings ever considered for promotion of venous return for the client, maybe before the development of the blisters?
I don't know if you got the question.
Yes, we did get the question. Thank you. Let me just say no.
Thank you. Thank you. I don't know if others have a question. It's a very interesting case. Suffering one in the same condition for such a long time is not an easy thing. And I've seen that this is a married woman. He once presented with a septic wound smelling. I don't know. You know, having a family member and the other is the flying members is not easy. I don't know if you were able to ask how has this condition affected her social, spiritual, emotional, and occupational life. You know, that now he has this condition for such a long time. It sometimes becomes septic and then smelly, and this is a teacher, and this is a married woman. I don't know if it's still, but the fact that is married, it means not widowed yet. There is a husband, there are children, there are friends, you know. How has this affected the woman? Has she not associated this with any spiritual things? How has this affected her life so far? I don't know if you were able to get that, because what I'm seeing for now is that she was referred to you for pain management, but I think there's another bigger pain behind the physical one that we are seeing. I don't know if you can say something on that one, and then maybe we close it also.
Okay. We do have a form on psychological assessment. So on questions like that one, we do ask our patients. Yes.
Would you
Or
share,
with this case, what, Mr. Matlang?
would you share what our patient said?
Oh, she did say that it has affected her a lot, because mostly her work is demanding her to stand most of the time, but she can't do that now. So most of the time she has to be in the hospital, and it's really affected her.
Thank you. Maybe because of time, and I'm not seeing anyone raising their hand or saying something. Thank you so much for such a case. What I can say on this, I think it is very important that such patients, that now we see them going through such, especially patients with a non-healing wound, sometimes becoming septic. I'm just disturbed by other calls in another meeting here. We encourage that we also look at how the patient is coping with such. We don't want to see people killing themselves. We don't want to see people living with depression, because, you know, when you have such an unhealing wound, and maybe are not even diabetic, people begin to say stories where that you got this wound from a funeral. You know, the spiritual art, they come up with stories and it haunts the patient. So I think with such a patient, the time to sit down and discuss with the patient on how best she can be assisted psychologically and emotionally. Gratefully, your team have social workers and psychologists. I think we need to dig deeper on that side of her life, on saying how best you can, and even how does it influence her family role, social role, be affected how much? Because we understand it's a woman and is still at 40 years, something years, and she's still productive as she can, but because of this wound, she's unable to cope with the situation. So I would recommend that you invest on that one, because looking at the condition, I'm not sure the history of when did it start to make him become unable to walk freely. We don't know. And the issue of occupational health, how best can the woman be productive at work with the limitation of the disease? Because if she is saying now, I'm unable to stand, yet my work requires that, you will find that maybe the social worker will need some time to meet even his managers. If he's not the head teacher, maybe to meet the head teacher and her consent though, if she will need such a support, that the head teacher can be educated on how best she can have her within the facility with the limitation, because you will find that she's pushing because of the socio-economic status at home. How is it that even if the environment at home, that a lady having a septic wound while still fully functional, it's a problem. I mean, maybe it's an issue of not knowing how to best manage a wound, but I've seen that you tried to do that and she came back with the outcome. But I will strengthen that, go back and strengthen the issue of spirituality, because it will help her to cope with the wound, go back to see the family support, because if it's working and it has already begun to frustrate her, that sometimes has to leave work to this. We need to find a way how best she can be at work and be productive with the same condition. And the issue of family role, to find out if she has not lost identity as a woman, and then we'll be able to build on that area. We will discover that once emotionally and psychologically strong, even the immune system stands on itself, and you'll find that she's becoming better and better, while other means are being done. Because now even the biopsy has been taken, I hope she has been formed just to confirm if there's no case. These days, she is in the forest looking for what is cancer. Can I be having cancer? What is the meaning of my life? You know, the anxiety must be very high when she comes there. But I think with the support of that, she will be fine. I'm seeing a head here. That would be from Andy, and I'm giving her only a minute because we are already ahead.
It would be maybe to add on what Ms. Mahlangu has said, that as nurses, whilst we are assessing pain, since we know that it's a continuous assessment, we should have that patience for our clients, because some you may need to re-explain your assessment scale again with every pain assessment. And also, as much as the nurse-patient ratio is not what we can wish for it to be, but we should have it in mind that if the client is now in front of you, when you are doing the pain assessment, at least do it with justice, and also to remember to document everything, and also the pain scale, the type of the pain scale that has been used, and to also maybe consider the patient's past experience with pain, because some patients you can explain the pain scale assessment maybe, and they would feel that their pain is a 3, but then they will exaggerate it to a 5 because they are thinking of that time when they had severe pain and they didn't have maybe quick access to hospital. So they will tend to exaggerate their pain level for the time when you are not there. Yet it is not good for the treatment plan because it will seem as if the pain medication is not working. Thank you.
Thank you. I hope RFM, we have learned a lot from your case. It's an eye-opener even to us, and even the skills we have used to assess the pain. I think another thing to add is that for the Wonga phase, it is the patient who has to show you which phase represents her own feeling of pain. And then the flag scale is your objective assessing the pain, or the caregiver assessing the pain. And then the numeric and the hand, it's all the patient saying what is the patient feeling. It's all subjective. Our next session, we will be rounding up pain assessment. We have done the qualitative, then now we have finished the quantitative. We will be looking at how best we can do it for the non-verbals. After that, the cognitive impaired patient, how can we assess cognitive impaired patients? It will be on the 2nd of November, 1300. So we'll be doing how best we can assess pain for the cognitively impaired. The issue is leave no one behind in pain assessment and pain management. No one deserves to experience pain. Mr. Ada used to say last time, he said, the major goal is to promote comfort. We don't segregate people with their abilities or physiologically, but we are saying to them, whether you are cognitive or you are cognitive impaired, we are saying you don't deserve pain. And you deserve the best of care as optimum level as you can. So we'll be looking at that one. Then after that one, we'll be embarking on pain management, and we'll be seeing the steps, the little bit on how best we can then manage the pain that we have assessed. So thank you so much for attending to this session. For anyone who needs today's presentation, it is available. With me, you can contact me on my number, 7629 7140, or you can just convert that one to Swaz mobile, and then we'll arrange and you will get today's presentation. And then we request that if you are leaving this site, kindly please click on our feedback form and share with us your feedback. Thank you, and thank you. See you on the 2nd of November when we are looking on cognitive impaired clients. Thank you. Bye-bye.
Bye.
Thank you. Thank you.
Bye, thank you.
Can we close, Mr. Masambu?
Yes, we are done.
Thank you. Bye-bye.
Bye-bye.